Welcome to theheart.org. Today we're discussing some of the hotline and late-breaking sessions here at ESC Munich 2012, and I'm privileged to be joined by João Lima, who's from the Hopkins University, Baltimore, and he has a study being presented here in the late-breaking sessions called CORE320. Welcome, João. Now, as I read this, there are a lot of words here that need explaining. It seems to be that you're looking at the diagnostic performance of using CT with non-invasive angiography together with some functional assessment. And of course, these are great combinations because you have anatomy and function, which is what we always want in one test. So explain to me and to the audience a little bit more about the techniques and the equipment and the imaging modalities, please.
Well, first, thank you for taking the time to talk to me about the study, and we are very excited about it. The underlying rationale for this is the realization that coronary artery disease is becoming really widespread in the world, and the technologies that we have to address them in industrialized richer countries are being overwhelmed by the size and the scope of the problem. So we are in search of new technologies that could at one point be reduced to practice in any environment.
Right.
And CT lends itself to that because CT is already used everywhere, and CT has been shown to define the anatomy well. So this study, the CORE320, is a follow-up to the CORE624 study, which was a study to define anatomy. This study is designed to define anatomy plus perfusion.
Yeah,
so
perfect combination.
The functionality of a lesion.
Yeah.
At the same time, the field of cardiology has moved towards focusing on the flow-limiting lesion as opposed to the anatomic stenosis alone. And so it is very apropos that we develop technologies that are directed to detecting the flow-limiting lesions. So the gold standard here was an anatomic lesion defined by invasive angiography that corresponded to a perfusion defect by SPECT.
Okay.
So that was the gold standard. The test case was a CT study done at rest to define the anatomy.
Yeah.
And then the patient stayed on the table, and 20 minutes later, giving adenosine and the same CT test now to define perfusion. So we looked at the question if whether the combination of stenosis with a corresponding perfusion defect by CT could index stenosis and a corresponding perfusion defect in that patient by the gold standard.
So it was the same patient who had both angiography, normal routine coronary angiography, and SPECT, and then had a second procedure or diagnostic procedure of CT with SPECT. Is that
correct?
Okay.
CTA and CTP.
Okay, so tell us how many patients were in the study and the design.
Right. The 381 patients were finally used in the analysis, although 430 were enrolled in the study, but the ones that could undergo all the tests and had images available were 391 actually had the CT study done, and 381 had the CTA and the CTP study.
So you started off with how many?
With 430.
So is that something about the limitations of CT in terms of heart rate and rhythm and all that? Was that the reason that this number dropped?
the majority of patients that dropped, let me go over the sequence of the study so
Please.
that the patient that was referred to cardiac catheterization was eligible. And at that point, if the patient had a clinical SPECT study, that SPECT study was used.
Oh.
Okay. If not, then a research SPECT study was performed, and then the patient had CTA and CTP.
Yeah.
Now,
CTA being just the CT, CTP being the CT after the SPECT.
That's correct.
So
That's
we're clear
correct.
then.
And now a few patients that enrolled ended up not having the catheterization for different clinical reasons.
Yeah.
So they couldn't really enter the study because they didn't have the gold standard.
Yeah.
And there were some other limitations of people who didn't have the SPECT or the SPECT didn't work.
Which is why we got to the funny number of 381.
And 81.
Okay.
That's how we.
So tell us what happened in the 381 patients.
On the 381, the power to detect a patient with stenosis and a corresponding perfusion defect by the CT test was expressed as the area under the curve was 0.87 for the lesion, for 50% lesion, and 0.89 for 70% lesion, with a corresponding perfusion SPECT defect.
Yeah.
So that's a robust power when you consider that the gold standard here, the bar is raised. It's the flow limiting lesion, is no longer the obstruction alone.
Okay, so this is really important because what you're avoiding is coronary angiography, FFR, and all of that, and the access complications perhaps, and all those other things. And what we're getting here is the anatomy and some function regarding the flow limitation of particular lesions.
Correct.
Okay, so where does that leave us? Do you think this is going to become a substitute for what we call cath query or cath query proceed? Because you're still going to have to go on and do angiography for those patients who require PCI according to your data. So where's this all going to fit? What's the message for the audience out there?
Thank you. This is very important. We had a secondary endpoint, which was, okay, let's make the gold standard revascularization at 30 days.
Yeah.
And let's see how the standard tests, which is the combination of invasive angiography with SPECT, compare now with CTA and CTP.
Yes.
They were equal at defining revascularization. So where do we think that's going to go? Like you very cleverly expressed, we aim to avoid going to the cath lab for any diagnostic work. So if we can predict exactly who's going to have revascularization, we would like to define the anatomy and the functionality non-invasively, and then go to the cath lab only with the patients that have a flow-limiting stenosis, who we know will have a revascularization procedure.
Okay. One final question I'm sure the audience will want to hear is it possible, because of the risk of excess radiation with the CT, is it possible to get rid of the first CT? In other words, can you just use the second CT with SPECT?
This is an excellent question. How this technology at the end will be used in mass is to be defined, because the way we did CORE320, we did the rest study first and the stress study afterwards. We think that in practice, half of the people will not need the perfusion study because they are not going to have important lesions by the rest angiography. So right there, you're already taking perhaps half or 2/3 of the patients out of the equation. Now, it is possible that in the future people will make the likelihood decision of who is likely to need perfusion or not, even before the CT is done, by clinical characteristics or by
Likelihood. Risk scoring.
Exactly. And just say if your likelihood is high, you go to perfusion right away.
Okay.
And you have only one.
Okay. So, fascinating data. Almost more questions than answers, but certainly very intriguing. And what we'd say is it's out there, watch this space, and maybe we'll have a better way of managing patients with chronic stable angina in the future.
In the end, that's the goal.
Thank you very much, Dr. Lima. An excellent study and very well done.
Thank you.
Bye-bye.
Bye-bye.